My very dear friends and colleagues, I am extremely sorry that I cannot be with you in person this time and to have addressed you via the internet. But I do hope to see you all in the not distant future. These are my disclosures, and I will discuss today the role of LH. First of all, I would like to tell you that LH is a glycoprotein dimer composed of two glycosylated, non-covalently linked subunits designated alpha and beta. The alpha subunit is composed of 92 amino acids and is encoded in the long arm of chromosome 6, and the beta subunit is of 121 amino acids and is encoded on the long arm of chromosome 19. The hormone's corresponding receptor is the LH receptor, which is also the HCG receptor, and mutations of the LH receptor can lead to inactivity or overactivation of LH. Please remember, the initial half-life of LH is about 1 hour. The terminal half-life via the IVF route is 11 hours, and the subcutaneous route is between 21 and 24 hours. Already in 1961, Ken Ryan demonstrated or contemplated that the T cells will convert cholesterol to androgens. The androgens will be transferred to the granulosa cells. FSH will stimulate the granulosa cells to produce aromatase. Aromatase will transform the androgens into estrogens, and furthermore, of course, FSH will cause replication and follicular growth. So 1 year later, we tried to prove the theory of Ken Ryan, and we demonstrated that the pure FSH, purified by immunological purposes, will stimulate follicular growth, but the uteri of these animals will remain infantile, meaning that FSH stimulates follicular growth, but no estrogens, whereas HMG, FSH plus LH, will stimulate both follicular growth and estrogens, which will stimulate the endometrium. Furthermore, we then labeled HCG in our reactor at Dimona with iodine 131 in order to determine its uptake in the ovary and its localization. We demonstrate very nicely that when we sacrifice the animals, we can see that in the circulation, the radioactivity decreased, whereas in the ovary, the concentration increased significantly, as you can see here. Furthermore, when we sacrifice the animals, we can see that the radioactivity, the HCG activity, was located on the ends of the follicles in the theca cells, as you can see here very nicely. And this was published already in 1967. So what we know now is that FSH-dependent granulosa selectivity improved when a recombinant LH is given during controlled ovarian stimulation. The LH increases ovarian follicular angiogenesis via modulation of VEGF-A and the soluble receptor FIT1, and furthermore, it was shown already by Gutmann et al. In 2008, and LH improves follicular recruitment, as shown by Gomez and Palomas in 2005, and LH also increases follicular maturation, a higher expression of maturation markers like TGF-beta, prostaglandin endoperoxide synthetase 2, and hyaluron synthetase 2 in cumulus cells. And the expression of HS2 was 6-fold higher in cumulus cells, yielding higher grade embryos versus lower grade embryos. Also, the LH receptor expression in human granulosa cells changes from antral to pre-ovulatory follicles. As granulosa cells develop from small ventricles to pre-ovulatory stage ventricles, there is a sharp increase in the LRH receptor from 1.3 to 12.8, at nearly 10-fold increase, and there is a very sharp increase in the gonadal aromatase receptor, which goes from 67 to 1,182, whereas there is a decrease in the FSH receptor from 138 to 26, and to the androgen and the decrease in the androgen receptor from 67 to 12. So LH has different roles in different parts of the cycle. In the early follicular phase, LH acts on thecal cells to produce androgens, which seem to be necessary for the recruitment phase and sensitize the granulosa cells FSH receptor. I will come back to this in the end when we talk of poor responders. In mid-cycle, LH stimulates the thecal cells to produce testosterone as a substrate for the production of estrogens. LH is also responsible for the maturation of the oocyte and induction of ovulation naturally, as you all know. Following ovulation, LH is responsible to maintain the corpus luteum until in pregnancy, the placenta will take over by secreting HCG. LH deficiency can be defined or manifested in female as delayed puberty or at any age, resulting in reproductive abnormalities that can dramatically or be subtle. The hypothalamic suppression of LH can occur in women under physical or metabolic stress or iatrogenic when gene-rich agonists or antagonists are administered together with FSH in controlled ovarian stimulation. Genetically, it can be induced by nucleotide polymorphisms of the LH receptor or by LH polymorphism like the V beta LH genome. What is the dose of LH when we need to supplement it to FSH? Addition of LH was shown to be effective in women with severe FSH and LH deficiency, supporting recombinant FSH-induced follicular development. In an open-label dose-finding study, women with hypogonadotropic hypogonadism were randomized to receive recombinant LH in combination with 150 IUs of recombinant human FSH. Women treated with 75 IU and 225 IU, respectively, had a good or excessive follicular growth. The study demonstrated that although LH requirements varied, a daily dose of 75 units was effective, as I will show you now. You can see here very nicely, when we tried to add to the same amount of FSH, 150 IU, different amounts of LH, 25 units, 225 units, 75 units, you can see here that the 75 IU units produced more follicles than the 225 IUs. Today we know that excessive LH leads to atresia. So the 75 unit seemed to be better for follicular growth. Furthermore, when we looked at the estrogen levels, we saw again that with 225 units, we get an excessive estradiol, and thus it was decided to use the dose of 75 units to 150 units of FSH. The study confirmed that recombinant FSH 150 IU plus recombinant LH 75 units is the most appropriate dose schedule for hypogonadotrophic anovulatory women. Sufficient follicular growth and development was observed in 94% of the women in 79 of 84 of initiated cycles. 5 cycles in 3 patients required a dose increase, and pregnancy was achieved in this hypogonadotrophic woman in 15 out of the 38 women, in 39.5%. Now the question was again, do gene-rich agonist protocols decrease embryo availability? A randomized controlled study with 30 egg donors, all receiving a long agonist protocol, was done. 19 were controls, which received 300 IUs of FSH, and the second group was 300 IU of recombinant FSH plus 300 IU of LH when 2 follicles were greater than 14 millimeters. In the group receiving LH, there were significantly less 3 the embryo rests. You see, 73 here and in 29 here, a significant decrease. And a significant more 5-day embryos available for transfer, as you can see here. Instead of 6, you had 15, also highly significant. Oh, sorry. Clinical pregnancy rates and delivery rates were better in the LH group, but did not reach significance. You can see here 31% implantation rate, and here 52.4, but not significant. And the clinical pregnancy again was 52% against 79%, but again it nearly reached significant, but was not exactly significant. The same thing with the pregnancy delivery rate. You can see here again, between 52% and 63%, a tendency to be better, but not significant. Now, the next question was, is there an increased frequency of low LH associated with increased early pregnancy loss in IVF and ICSI cycles? And this was a study done by the group of Chinda Cheng on 1,094 cycles with flexible gene-rich antagonist cycles with recombinant FSH and fresh embryo transfer, and LH measurements were performed every other day. And you can see here, low LH, which was classified as less than 0.8 milli-IU per milliliter, anytime during the COHS cycle occurred in 22% of cycles. One-third occurrence before initiation of the gene-rich antagonist. An increased frequency of low LH episodes will increase the probability of pregnancy loss. Now the next question was, can LH supplementation rescue antagonist cycles with low intercycle LH levels? The conclusion of this study was, although it was a relatively small study, it demonstrated a significant higher number of eggs and a higher live birth rate in women given LH supplementation in antagonist cycles in which the intercycle LH levels were low. Monitoring indicates this occurs in over half of antagonist cycles. Remember, a low LH monitoring showed that this can occur in over half of antagonist cycles. But the live birth, again, you can see here very nicely the increase here from 30 to 43.7% in the group with LH. And it's interesting to see here, in the group with low LH, you can see here very nicely a low pregnancy rate and a low live birth rate. When you add the LH, you will receive this significantly higher rate, very similar to the group who were constantly at a normal age during the entire group. Now let us see what happens in aging women. Also there, we believe there is an LH deficiency. And the LH deficiency in aging women is due that aging women, the ovary has less functional H receptors. It was already shown by Bifko in 1996. In the aging woman, the endogenous LH is less potent and biologically active bioactivity, as shown by Mitchell in 1995, due to an increase of sialic acid, and it has an impaired ovarian pericrine activity, as shown by Horowitz. And this decrease is demonstrated when we look at the testosterone, DHEAS, in free testosterone, androstenedione, that there is an increase in total testosterone, in DHEAS, in free testosterone, and in androstenedione levels, showing the LH deficiency. Supplement of LH in the aging ovary help us. We know today that LH upregulates growth factors, the basic fibroblast growth factor, FGF2, and the androgen receptor, and the estrogen receptor, and acts synergistically with IGF-1. LH reduces apoptosis of cumulus and granulosa cell, and enhances the expression of anti-apoptotic proteins. A meta-analysis demonstrated that recombinant LH supplementation improves implantation rate in older women compared to recombinant FSH alone. As you can see here, very, very nicely. It is very significant in all 4 of these papers, as experiments. But then we have another situation, which is very interesting, which means follicular output rate. We consider a normal follicular output rate when more than 70% of the small antral follicle develop into pre-ovulatory follicle. In hyperresponders, when we only see 20% of the antral cells develop into pre-ovulatory cells, this we call a decreased follicular output rate, and we see this very often in hyperresponders. Now, this can be due to low gonadotropin starting dose. It can be due to genetically environmental factors. It can be due to uncrinous follicular development, and it can be due to technical issues involving the triggering for final oocyte maturation and/or ovum pickup. LH supplementation is able to improve both ovarian response and outcome of IVF in V beta LH carriers and in women with hypersensitivity to FSH. So how can we rescue follicular output? If you add 150 units at about the 6th day of stimulation, or 75 units if unsuccessful, so in the next stimulation, add 75 units from the first day of stimulation. And then when you do this, you may rescue follicular output. So if you have a cycle and you see a low development of follicular output between day 5 and 8, add your LH, and very possibly in about 60% of the cases, you can rescue this. And if not, start the next cycle by adding 75 units of LH from the very beginning of the stimulation protocol. Now, this was also now shown by some groups later on, that LH supplementation significantly improved follicular output rate, is demonstrated by an increase of oocytes, by an increase in mature oocytes for 4.7 to 7.8, an increased implantation rate between 14 or 36 or 10.5 to 14 by Pareto or the placebo, and increased in pregnancy rate. Also, you see very nicely here by all the 3 groups a significant increase. Hyperresponders and LH increased implantation rate. This was another study done by Alvigny a little bit later again, which demonstrates exactly the same effect again, where you see all groups showed very nicely an increase in the implantation rate, and which was, of course, significant when you took all of these together. In the forest plot of odd ratios for the single pregnancy rate in recombinant FSH plus LH versus FSH alone treatment, again, this analysis indicates that women with a previous hyperresponse to exogenous FSH stimulation benefit from LH supplementation as a means of increasing clinical pregnancy rate, as you can see here very, very nicely. But what is this treatment strategy? When should we add LH in advanced maternal age? We are talking here all the time of women between the age of 36 and 39. Why is there a lack of general agreement? So Berry made a very nice experiment in a randomized controlled clinical trials with gene-rich agonist protocol. Group A had recombinant FSH plus LH from day 1, and the group B had recombinant FSH plus LH from day 6. He demonstrated very, very nicely that the group which received LH from the very, very beginning was significantly better in implantation rates, in clinical pregnancy rate, and in clinical empathy by embryo transfer. You see, in all the situations, group A, which received LH from day 1, was significantly better. Now, we start thinking, what do we do with the very poor responders? Here, there is very little we can do, but many things are being tried to do here. And one of the things is, can we do priming of the seeker cells to produce androgens in the seeker cells from the very beginning? So in this experiment, where they used long agonists, 150 IUs for recombinant FSH, 4 days, and this was followed by 400 IUs of recombinant FSH. And you can see here, whereas in the previous cycle, there was 0 live birth rate or 0 live birth rate per patient, you get here a very nice 24 and 29%, which is of course excellent for these very poor responders. So we can see here that LH pre-treatment decreased cancellation rate and significantly increased live birth rate. Another randomized trial performed in 2014 showed exactly the same thing. The group which received 400 IUs per day was group A, and the group B was 150 IU of FSH, of added of LH for 4 days, followed by 400 units of FSH. It means they received 150 IU of LH for 4 days, and this was followed by 400 units of FSH afterwards. And you can see here again that this group, although it's a smallest experiment, again had a better pregnancy rate, a better implantation rate, and a better live birth rate. 5 to 32, extremely better, so it's highly significant. So we can see here, pregnancies, implantation, and birth rates per patient were significantly higher in the group which received LH with the group A against the group which did not receive LH. My conclusions are, LH during ovarian stimulation exerts stimulatory effects on FSH-dependent granulosa selectivity in steroidogenesis. The benefit of LH supplementation to FSH in patient subpopulation, it will be of benefit in the hypogonadotrophic hypogonadism, ovulation induction. It will be of benefit in the FSH receptor or LH or HCG receptor or LH gene polymorphisms patients. It will be beneficial in patients receiving gene-rich long agonists as well as agonist cycles and with deficient LH, less than 1 milli-IU of LH detected during treatment, which are used, these patients are usually deficient also in E2 and estradiol response. There will be benefit of LH in patients older than 35 years. LH will benefit patients who are hyporesponders. LH will benefit patients who have a deficient follicular output rate and in severe poor responders as a beginning of the treatment. But again, whenever you do this, we suggest you should start LH supplementation on the first day of controlled ovarian cycles. And with this, I thank you for your attention. I hope next time this will be together with you and we'll be able to celebrate the end of the pandemic. And if there are any questions, I'm ready to answer. Thank you all. Keep well and safe, and see you soon.